Hello everyone, this is Michelle. I wanted to do a abbreviated lecture for you because what's going to be happening for our class period for mood disorders is the first half, obviously you will be having an exam, and the second half they've scheduled a FAST meeting at the end of the class, so that will shorten up our class period by 10 minutes, leaving us maybe a half an hour to be able to do something. So with the limited time, I thought we could use the half hour during class to play a Jeopardy game, and I can record this lecture so that you can review some information prior to class. So what we're going to talk about first is major depressive disorder. I'm sure all of us, I would go out on a limb to say that all of us have experienced some level of sadness in our lives. Either, it's a failure of an exam and you feel bummed out for a couple of days, and then, you pull out of it and try for the next one and exam and do really well, and you're happy again. Or, perhaps it's the loss of a loved one. The grieving process, does, have sadness with it, can last for some days. But typically most people will, come out of the grieving process after some time. So what makes sadness that we've all experienced different from major depressive disorder? And that is the symptoms, the depressed mood. They have decreased, wanting to partake in things that they normally would want to partake in, including working. They have changes in appetite. Their whole body just feels fatigued and they're slow. They have feelings of worthlessness and hopelessness, helplessness. All of these symptoms that you see on the screen, the key is that this goes on for 2 or more weeks. That gives them the diagnosis of a major depressive disorder. So what causes this? There's 2 thought processes. One is that it's genetic, and the second is that there's a chemical imbalance in the brain. And this chemical imbalance is specifically related to serotonin and norepinephrine levels. I did want to give you a visual here of what the brain would look like. Excuse me, let me get rid of this. What the brain looks like compared to a normal brain when somebody's having depression. And the green and blue areas usually depict lower functioning or lower activity in the brain, and the oranges and the reds are therefore higher activity levels. So you can see here we've got some yellow and some orange, a little bit of green here and blue. And when you compare that to the depressed brain, look up here in the frontal lobe, where you have a lot more green, where it used to be more orange and yellow. And what the frontal lobe of the brain contributes to our ability to concentrate, to plan, to make judgments. It affects, the frontal lobe affects our emotional expression, our creativity, and our ability to have inhibition about things. And again, and if you look here also, we have a lot more green activity going on back here, which is the parietal and temporal areas back here, and that affects our muscles, and the parietal is our sensory input, and so that is inhibited also. So let me get out of this screen here and get back to the PowerPoint. So that being said, research has found that first-degree relatives of somebody who has been diagnosed with depression are 3 times more likely to have depression themselves. It is more common in women, And people who are depressed, or excuse me, who are diagnosed with depression are 60% more likely to have subsequent episodes. And why that's important is because if a person is diagnosed with depression and put on some medication, they may think that they're all better and everything is going to be fine from there. But again, 60% will have subsequent episodes of depression, and I think that is thought to be because people will relapse, they can build up tolerances to the medications and need to have med adjustments. Oftentimes, depression coexists with other mental health disorders, especially anxiety, substance abuse, alcohol abuse. And the thought behind alcohol and substance abuse is that people who are depressed will try and self-medicate their disorder through the use of drugs or alcohol. It also coexists with personality disorders and chronic medical conditions. And we see this a lot with the elderly population, people who are dealing with chronic pain, maybe somebody who's had a stroke, they'll have some subsequent secondary depression with the loss of their independence, or if they're continuously feeling ill over time, this wears on a person and they can get secondary depression symptoms. Depression is present in all cultures, all age ranges. There are some differences in how different cultures will present their symptoms to you when they're coming in. For instance, the Asian culture tends to come in more with somatic complaints than actually to label their symptoms as depression. Hispanic population, they tend to use the term nerves rather than depression when they're describing what they're feeling. Again, depression is quite common in the elderly, could be related to dealing with chronic medical conditions, but oftentimes the elderly are misdiagnosed with having dementia rather than the true diagnosis of depression. And we're going to, later in the lecture, we are going to compare depression and dementia and delirium, and so that you can try and differentiate between the conditions. The elderly population has a decreased tolerance to medications that are used for depression because they're not able to deal with the side effects as well, and oftentimes because the elderly have some renal, liver decrease going on with aging, they're not able to tolerate the dose levels that are needed to be therapeutic for depression. So what they're finding is that the elderly, actually the suicide rate is double that of the general population with depression, especially for elderly that are 65 years and older. So other mood disorders that are related to depression, the first one, cyclothymic disorder, is actually has manic symptoms and is associated more with the bipolar disorder, which we're going to talk about next. But what's important with the cyclothymic disorder is that these hypomanic symptoms typically are not severe enough to be diagnosed, for the person to be diagnosed with bipolar, and so they get diagnosed with this disorder instead. And another key aspect of this is that these symptoms have to be going on for 2 years or more to get this diagnosis. Dysthymic disorder is depressive symptoms, but they're mild. Again, the depressive symptoms are not severe enough for the person to be diagnosed with depression. And again, this must be going on for 2 years or more to get this diagnosis. Seasonal affect disorder, I think most of us are probably familiar with this, maybe have struggled with this, being that we live in Wisconsin, and it's cold. Typically we don't go outside as much. We lack the normal rays from the sun, and so this can affect us, and it would be labeled a seasonal affect disorder. What happens with this disorder, since we don't get the sunlight, is it disrupts our melatonin production, and it decreases our ability to process dopamine and norepinephrine, which are really important for our emotional stability. So what people usually will experience is some fatigue, increased appetite, especially for carbs. They may gain weight, and they may be kind of irritable. Usually seasonal affect disorder is not treated with medication or counseling. The number one recommended treatment for this disorder is light therapy, especially full spectrum light therapy. And these are just little light, it looks like the size of a piece of paper. It's a box with the lights in it, and a person will sit in front of this light for anywhere from 30 to 45 minutes a day to try and get that, to simulate that natural light we would be getting from the sun. And this has been shown to help people come out of a seasonal affect disorder. Light therapy is also used as a conjunctive therapy for major depressive disorder also. The last one there, postpartum depression. Postpartum depression can be, not everybody gets it, but can be a normal reaction to the fluctuating hormones after a woman gives birth to a child. Symptoms of this would be depressed mood, maybe some crying, inability to sleep, anxiety, irritability. And these symptoms or postpartum depression does meet the criteria for being diagnosed with depression. The concern here is that if you have a depressed mom, that's going to interfere with the mom-baby bonding, and that's essential in those first few months of life for the baby to have that bonding with the mother. Now, postpartum depression can get so severe that the mother can actually have some psychotic components to the depression, such as delusions, hallucinations, poor insight and judgment, and just loss of contact with reality. Postpartum psychosis would be considered a medical emergency, and if you are talking with a mother and she's acting or exhibiting these behaviors, you would not want to leave that mother alone with the baby. There could be some risk of harm to herself or the child, so you would want to institute some intervention immediately in that situation. So following the nursing process, of course, we would begin with our assessment. Patients most likely are not going to present to the clinic or the hospital by stating, "I'm here because I'm depressed." More likely, they're going to come in and have more vague complaints. So I always like to start out my assessment by asking the individual, "So what brings you in today?" and give them the opportunity to describe what their symptoms are, what problems they've been experiencing. And then, from those statements, you're going to be able to obtain some information and clues as to if this possibly could be depression, and then taking that assessment further by utilizing some screening tools such as the Beck, Hamilton, and Zung, which I've put on the slide for you. And just, making note of your observations and the patient's statements that would support that perhaps they're having some depression. Patients may not be cooperative, especially if they're having a severe episode of depression. They may just want to be left alone. They may not be very quick to give you answers to your questions. And what's important is not to rush the client or the patient, but to allow them some time to answer your questions, because again, you know, those thought processes and mental processes in the brain are slowed down with depression. So it may take the individual a little bit of time to process what you're asking them and come up with a response for you. So just try and be patient. And if the individual isn't really able to give you a lot of information, hopefully, you know, you can obtain some information about their support system or their family members, and if they're present, perhaps they could supplement your assessment information. So it's always good for the nurse to establish a relationship with the family or a significant other, or whoever their support system is, because in the end, when you're making your plan for the patient, it's going to be really important that you include those people to educate them and follow through with some referrals that you're probably going to be giving. Again, you know, to assess cultural aspects, always asking the patient what their perception of the problem is and what they think needs to happen. So I know the Native American, the Hispanic, and even the Asian populations, they have a belief that there's a balance between hot and cold. So they may feel that that is what they need to remedy the problem. They also believe in healers and herbal remedies. So always, you know, putting out that question to them of what their perception of the problem is and what they think needs to happen will help you determine, you know, what the cultural aspects that you have to take into consideration. The next slide is nursing diagnoses. That's pretty self-explanatory, so I'll just let you review that on your own. Nursing interventions. So number one, if you determine any concerns that the person may have depression, there also comes the concern of, is the person so depressed that they are contemplating suicide. So we always want to be asking those questions if they've had any thoughts of harming themselves or anybody else. Should that answer be yes, your number one priority is going to be to provide safety. And you would want to institute some suicide precautions, which would include making sure that there aren't any harmful objects in the room that the patient could use to harm themselves, and increase supervision. I would go as far to say that it should be continuous supervision until you have resolved or started them on some therapeutic intervention. The nurse needs to establish a therapeutic relationship with the person, and what that would entail is you know, non-demanding short visits with the patient. You know, just coming in to talk and not having anything that you need to accomplish or have a request of them. Just being able to talk with them, even if they don't want to talk, even just sitting there with them in silence shows that you are interested, that you care about them. And that is the beginning of a therapeutic relationship. Again, allow for some pauses, some patience, so that they can process what they want to say. Again, with those slowing of the mental processes, that's really important. And just one thing is not to be overly cheerful or try to cheer them up, because actually what that does is shows a lack of understanding of the despair that they're feeling. So by being cheery or trying to cheer them up, that really is more detrimental than it is therapeutic for that person. So let the patient talk about their emotions, encourage them to talk, and don't try to fix the problems for them or use cliches like it'll be better in a little while, because what that does is just kind of belittles the patient's feelings again. Medication interventions for people suffering from depression, obviously it's going to be antidepressants. If the person is having psychotic symptoms, we may be trying to use some antipsychotics. And if they're irritable or anxious, we may also pull in some anti-anxiety medications. Tricyclic antidepressants are typically not the first line of treatment, and that's related to the multiple side effects that those antidepressants have. The monoamine oxidase inhibitors, again, also this would be a last resort antidepressant being used, and that is related to the high risk for interactions with tyramine in the diet. And also there are over 100 medications that have potentially dangerous side effects or interactions with these antidepressants, especially phenylephrine. Phenylephrine is a component that is found in many cold medications, and that is one of the contraindicated drugs for the MAOs. And what happens if they have interactions with tyramine or these medications is that the person actually will have a hypertensive crisis and can have a cardiac crisis also. So very dangerous antidepressant to use, and just again would be the last resort if none of the other antidepressants work. So what do we try to use? Because depression is associated with serotonin and norepinephrine levels, we will go towards the SSRIs and the select norepinephrine inhibitors. We always want to be checking a baseline liver and kidney functions, because this is where all the filtration and metabolism is going on, and so you want to make sure that the kidneys and the liver are functioning appropriately prior to beginning any kind of an antidepressant medication. And then there will be monitoring after the medication is started, just to make sure that those functions are maintaining. All of these medications, we are to educate the patient and the family members that there should be no alcohol or substance abuse. And I think I may have mentioned earlier the Hispanic and the Asian and elderly population. It has been found that they actually need lower doses of these medications than the general population. Antipsychotics can cause orthostatic hypotension, so you always want to be educating your patient on changing positions slowly, just for this fact. Antipsychotics can also cause the extrapyramidal symptoms, such as the dystonia, the tardive dyskinesia, and Parkinsonian symptoms. And one thing I did want to note, to make you aware of, is if a person is started on an antidepressant, for the first 2 weeks that they are on that, you need to be very, very cautious and be assessing for suicidal ideation. And the reason behind that is because people who are suffering depression, they will be very fatigued, not interested in doing anything. But when they start an antidepressant, they may get an elated mood, they may get an increase in energy level, but not to a therapeutic level yet. So they may be still experiencing those depressive symptoms, but the medication has allowed them just enough energy, perhaps, that there's a concern that they would go through with any suicidal ideation. So those first 2 weeks are critical in assessing for suicidal ideation. And then you're going to want to be educating your family and patients that they're not going to see an immediate effect with antidepressants. It's not like a magic pill or going to feel better tomorrow. Usually it takes 2 to 4 weeks before a person reaches a therapeutic level and is actually going to be able to take notice of change in how they feel. So that's always important to let them know that. Finally, if all of these medications are not working, another treatment modality is called ECT, or electric convulsive therapy, where actually they do they do an electric stimulation and produce a grand mal seizure in people. And the thinking behind that is that the grand mal seizure, they hope, will reset the brain, kind of like when we have patients who have an MI and we shock them. The hope is that, you know, the shocking stops the heart, and then when the heart restarts, it's going to restart back into its normal rhythm. Well, the same thing, the same concept is going on here with the electroconvulsive therapy. By the shock to the brain, what they're hoping is that the brain will reset back to a normal functioning level. And I actually did have a patient that I worked with. It was actually, I was working at an insurance company and I was the employee health nurse. And I had an employee that I was working with severe depressive symptoms, actually secondary to post-traumatic stress disorder. And anyway, this person was so depressed that it was interfering with their ability to function at work or perform their job. So he was at risk of losing his job. So what happened is he went out on some disability, medical disability leave, was put on medication, was seeing a counselor, not really getting anywhere, and they went ahead and ordered some electroconvulsive therapy for him. And when he came back at the end of his 6-month medical leave, it was amazing. I would not have known it was the same person. It tremendously changed life for this person. And I guess what I'm getting at is electroconvulsive therapy, there is a lot of controversy over it as a treatment in general. There are some that do not believe in it, and then there are others that do. So I did post on Blackboard for you guys a video produced by the BBC, and it is on electroconvulsive therapy. It is extremely interesting, and I would recommend that you watch that video on Blackboard because it will, you know, talk about both sides of the issue for you. And I also want you to watch the video because when I was a new nurse and I was doing my clinicals in nursing school, I was put on a behavioral health unit with a patient who did have depression and who was going through some ECT therapy. And personally, for me as a student nurse, it was a bit traumatic for me when I went and observed that procedure. So I would like you just to have some, what do I want to say, some exposure to what ECT therapy actually looks like in case you are in a clinical situation as a student and do observe that you won't be shocked like I was. So basically, the prep for this procedure is the same as you would do with a prep for any like a minor surgery patient. They're going to be MPO after midnight. You're going to want to be removing jewelry and nail polish, having them void prior to the procedure, and inserting an IV line. These patients do receive anesthetic and a paralytic agent such as succinylcholine, so that they aren't aware and don't feel anything during the procedure. Oxygen will be applied. Typically, these patients will go through 6 to 15 treatments, typically 3 times a week. Post-op, or after the procedure is complete, it's much like what you would be doing in a PACU. You're going to be waiting for the patient to awaken, monitoring vital signs, and waiting for the return of that gag reflex. Okay, patients are going to be confused after the procedure, and they may have some short-term memory loss after the procedure. So if you're familiar with or anybody who's had a grand mal seizure, they're very disoriented, and most likely they're going to want to sleep for some time after the procedure. They can eat if they want to because that gag reflex has returned. So other things, other nursing interventions, we've talked a lot about ways that you're going to, educate the patient and the family, especially about the medical condition itself, any goals that have been set, any follow-up treatments, including medications, but any follow-up appointments, say with psychotherapy. That's all going to be important education prior to discharge. Let's see, one thing I did miss that I wanted to tell you is that I mentioned that the elderly population needs lower doses of antidepressant. One antidepressant that has been found to be effective for the elderly population is Wellbutrin. Wellbutrin has been found to be less sedating and better for the elderly because they can tolerate the side effects better. So just one little tidbit of information that I forgot to tell you. So let's move on to bipolar disorder. Bipolar disorder basically is that you have depression. The depression is the same as what we've just gone through with major depression, but the difference with bipolar is that they have what they call manic episodes, which are on the other spectrum of the disorder. So you're still going to have your depressive symptoms, but then when they're in mania, you're going to have completely different symptoms that you're going to be wanting to look for and question the patient and family members about. So if you can think of bipolar as like a roller coaster, right? So you're going up the hill on the roller coaster, you reach the top. That's your manic episode, okay? And we'll go through some of the symptoms with the manic. And then as you start to come down on the roller coaster, this is where you get into the hypomanic episodes, where they're still having manic symptoms, but they're tapered, they're tempered a little bit. So these are called hypomanic. And then when you get to the valley of the roller coaster, this is when the person is going to dip down into an episode of depression. So what differentiates bipolar 1 from bipolar 2 is basically bipolar 1 is that they have more manic episodes than they do have depressive episodes. And vice versa, bipolar 2 is that they have more depressive episodes than they do manic episodes. Okay? Cyclothymia, again, was the disorder that they have hypomanic episodes for over 2 years of time, but the depression and manic episodes are not severe enough to be diagnosed with bipolar disorder. So bipolar is a chronic mood disorder. Basically, the hope is that to control the extremes, okay? So if somebody is put on medication for bipolar, what you're hoping is that the medication will bring them back down to a more neutral level where you're not going to be getting the peak of the manic and the peak of depression, okay? You hope to meet in the middle. Okay. Because bipolar is thought to be a disorder of neurochemicals and hormones, typically you're going to see a diagnosis or symptoms of bipolar more when you're having hormonal fluctuations. So puberty, you're going to see a diagnosis higher at adolescence, and then for women, when they go through menopause, again, you have these fluctuations in hormones, and so you could get a diagnosis later in life. Could be related to pregnancy, again, with those hormonal changes. It could exhibit itself at that point or with menopause. Typically, when a person is going through the bipolar disorder, they're going to have a manic episode first, followed by a hypomanic, and then dip down into the depressive symptoms. It interferes with the person's ability to function, and the manic phase can last a week or longer. Although some people do have what they call rapid cycles, rapid cycling, where they can have mania, hypomania, and depression all in one day. Typically, we see this more in the adolescent population because puberty, the hormones are changing so quickly that adolescents typically will have more of the rapid cycling. In between the mania and depression, once they run through that cycle, they can have some normal functioning, or we call it euthymic functioning, where they have some normal periods in between these episodes or phases. There's no cure, I think I already mentioned that, so patients and families really need to be educated on the disease itself and how to reduce relapses and increase their quality of life. Mood disorders are likely the result of, like I said, the complex interaction between neurotransmitters and hormones. Regions of the prefrontal cortex, again, being responsible for our concentration, our planning, our judgment, emotional expression, ability to inhibit inappropriate behavior, and the medial lobes of the brain dealing with sensory input, object recognition, area of the brain where you will get some of the delusional thinking and hallucinations. And those are the regions of the brain that are implicated in the pathophysiology of bipolar and the neural circuit disorder in the areas around it. So let's take a look at what that looks like compared to a normal brain. So it's obvious here, here's your normal brain, here's your bipolar brain. All this red, extreme activity, almost affecting all areas of the brain. And this is going to get you your symptoms of bipolar. So what are these characteristics or symptoms? Let me get back to the PowerPoint one moment. Here we go. Characteristics of a bipolar disorder. Again, the depressive symptoms are going to be the same as what we covered in major depression. The mania criteria is that they have inflated self-esteem, they have this idea of grandiosity, they go for days with no sleep, they just have such a high energy level that they can't sleep. They have rapid speech. There's so much activity going on in the brain that they have all these thoughts going through their head at such a rapid rate, and they're trying to get those out verbally, and so the speech is very rapid also. And they call this pressured speech, and it makes me think of like a pressure cooker, right? So you have all this stuff that's building up in their mind, and they're trying to get it out, and they can't get it out fast enough, and the pressure just keeps building and building and building until they feel frustrated and like they want to explode. That's kind of how I envision this, and that's kind of how it exhibits itself. And in a little bit, I'm going to show you an actual video of somebody in a manic phase so that you can get a feel for all these characteristics. They have flight of ideas, racing thoughts, they have psychomotor agitation, some delusions, hallucinations, and often will partake in risky, pleasure-seeking kind of behaviors. This euphoric mood is very unstable. So at one moment they could be joyous, and then the next minute they could be irritable and belligerent. So the person, is laughing, telling jokes, talking about uninhibited thoughts, and that usually can be often comes out in sexual connotations, extremely enthusiastic, may have these elaborate schemes on how they can get rich or acquire unlimited power, and the person may give away all their money, buy lavish gifts for people, spend money freely, go to parties, and just have be sexually indiscreet, join gangs, get in brawls. These are all the kind of activities that people who are in a manic phase will participate in. What the problem is, obviously maybe to you, the problem is when they come out of the mania and they see the destruction that they have caused themselves, it's startling. And this will only force them deeper into their depressive phase. People who have bipolar, they don't have the capacity, the mental capacity to realize what's happening to them and what effect this is having on their family members or significant other, their spouse. Okay, they just don't have that ability to understand it. Oftentimes, bipolar patients who are put on medication, when they get into this manic stage and they have all these grandiose ideas, also feel like they don't need to take their medicine anymore. So you have a high rate of noncompliance with medication with this population of people. We talked about rapid speech, vulgar language, extraordinary sexual inappropriateness, and okay, that's what I wanted to cover with that. So what are we going to do with our nursing assessment? Getting an assessment from somebody who's manic can be quite impossible. So one of the most important things that you want to do is, set up that therapeutic relationship again with family or significant others that can give you a better history on your patient than the patient is able to do himself. Essential assessment is the same as major depression, only you're going to want to utilize a different screening tool. The depression screening tools really are looking for symptoms of depression. The mood disorder questionnaire, which I did post on Blackboard for you guys, actually is looking for those manic components. Okay, so if you have any indication that this person is manic or hypomanic, I would say use the mood disorder questionnaire to try and get at that aspect of the disorder. Again, in your assessment though, honestly, I believe that you're going to be able to tell if somebody is manic or hypomanic just by your observations of that person and things the person is saying to you. Oftentimes, people who have bipolar are misdiagnosed with having depression, okay? And that makes sense because it all depends on when they come in for help. If they come in for help during the depressive phase, the practitioner may not know that this person has episodes of mania if there's not a family member or somebody else there to tell them that. Because remember, these patients don't realize or don't comprehend what's happening to them. So they may just come in and present with all these depressive symptoms, be placed on an antidepressant, and sent on their way. The problem with being misdiagnosed and put on an antidepressant is that antidepressants are not an appropriate treatment for people who have bipolar. Actually, antidepressants will potentiate the shifts and episodes of mania for patients. So the treatment plan, that treatment plan actually is much worse for the individual. Nursing diagnosis again, I'll let you review that on your own. Nursing interventions, therapeutic communication and building that therapeutic relationship is going to be very important. You may find yourself having to frequently repeat requests from the person, because remember, it's going to be hard for you to break through that rapid thought process that is going on in the person's brain. So you may have to frequently redirect them and be persistent with repeating your requests. You need to, state reality to the patient, but you don't want to get into a power struggle or argument with the patient about reality. State the facts, but don't argue. Okay? Always treat your patients with dignity and respect, even if they're having inappropriate behaviors. As mentioned before, they have no inhibitory aspects in their thought processes and what comes out of their mouth. So, if they're using bad language or being sexually explicit, treat them with dignity and respect. You can make statements to them that that's inappropriate behavior, and I'd appreciate it if you wouldn't do that anymore, but you never want to like scold them or reprimand them. That's just degrading for the patient. And I hope I'm not insulting you by telling you these things, but I would hope that everybody does know that. But when you get into these situations with patients and these things are going on, it's easy for it to get out of hand. So, always keep in the back of your mind, the person can't help it. Don't take it personally. Treat them with as much direction and authority as you can, while still maintaining that dignity and respect for them as a person. Health teaching is going to focus on information about the illness itself, the importance of medication compliance, symptoms of early recognition of impending episodes is going to be very essential, especially for family members. If they can catch the symptoms early on and treat those, you're going to keep the person from getting either extreme of this spectrum. The importance of regular sleep patterns, ADLs, hygiene, eating, drinking, getting regular exercise. Those are all important things that you're going to want to educate. Okay, so medications, I already mentioned that antidepressants are not an appropriate intervention for people with bipolar. Typically what is used is anti-manic agents or anticonvulsive agents, and the anticonvulsants are being used as a mood stabilizer. The number one medication that is used for bipolar is lithium. It has an 80% effectiveness rate for people with bipolar. However, the backside of that is that it has a very narrow window for therapeutic dose, and that would be 0.5 to 1.5. Okay, when you reach 1.5 and anything above that, now you're into a toxic situation or toxicity. And so it's extremely risky. And the reasoning behind this is because it's not filtered or metabolized in the kidneys or liver like we talked about with depression. Lithium is actually a salt, and it is absorbed by the body through the tubules in the kidneys. So that leans itself towards reaching that toxic level quite quickly, and it can be dangerous, okay? Anticonvulsant drugs are also useful for patients with bipolar who are not responding to the lithium, or they can't tolerate the lithium. So at that point, you know, anticonvulsants would be added to the drug regimen. One anticonvulsant, Tegretol, may be used in conjunction with lithium, and that one has been found to be very effective. Especially Tegretol has been found to be very effective for people who have rapid cycling of their episodes. Anti-anxiety drugs also can be used to manage that psychomotor agitation that we often see with mania. And finally, antipsychotics would be added if the person is having delusions or hallucinations. So the paperclip. I just wanted to put it out there that the video I'm going to be showing you of a person in a manic phase, the F word is used 4 times in the 5-minute segment. So I'm giving everybody permission, if they prefer not to be exposed to that kind of language, that you can go ahead and fast forward this lecture by 5 or 6 minutes to bypass the video. But I do want to say again that in reality, this is the kind of behavior that we are going to be exposed to with patients that we are dealing with who have mental health conditions. So bad language, inappropriate behavior is something that we should anticipate and individually come up with a plan on how you will handle that when you are in that situation. So let's take a look at this video, and then we'll talk about it after.
So hey, I don't know why I'm doing a video right now, because I feel it's so weird right now, honestly. But I guess I thought that it might help a little bit to do a video right now, because I am experiencing some massively manic symptoms right now, and obviously it's manifesting in a stutter that I never had when I was a kid. I never had a stutter. I never had anything like that. I had a bit. I mean, I had trouble making certain sounds when I was a kid, but I never had a stutter. So it's really strange that when I get into like this manic or hypomanic, I honestly don't know what to call it right now. But when I get into this kind of a stage, I start stuttering. I think it's because the thoughts are going into my head way too fast, and they can't come out of my mouth fast enough. So basically, this is what happens when I get manic, and the strange thing is that it shouldn't be happening right now. It really should not be happening right now. I got on Prozac last Monday, actually, because I was getting some really bad depressive symptoms, and I know I'm bipolar. I realize that bipolar people probably should be on medication. I mean, obviously, looking at me right now, I should be on medication, and I am on medication. And that's the funny thing, is that I'm actually experiencing this despite the fact that I'm on medication right now. So this is how absolutely insane this can get right now. Really like the only thing that I want to do right now is go out and drive about as fast as I possibly can on the freeway. You know, I want to go out and party. I want to dance. I don't know how to dance, but I want to dance for some reason. It's hard to understand how this is actually happening right now, because I was fine when I woke up this morning. I barely got any sleep last night. At least I think I barely got any sleep last night. I think I'm having this problem lately where I'm not dreaming, because I wake up, I can't remember any dreams, and I feel so incredibly tired. No matter how much I sleep, I can sleep like 8 hours a night, and I still feel so fucking tired, and it doesn't make any sense. And it really doesn't make any sense that I could have barely slept every night this week, and yet right now my thoughts are racing, my speech is racing, or at least it would be if it weren't for the fact that I can't seem to get the words out fast enough, and it's just driving me nuts. I want to go ahead and do something stupid. I want to. My brain wants me to anyway, but I can't seem to. You know, it's self-control. I have to be self-controlled. So you know, yeah, this is I'm sure anybody watching this right now thinks I'm completely insane, and yeah, maybe maybe it's somewhat accurate. You know, I can't keep the computer from shaking because my leg is shaking. It happens whenever I try to sit down, and you'd think that I could just go run around the block, but you know, I just have this energy, and yet that wouldn't help. It would just make it worse. The more that I actually do things, the more energy I seem to have, and it's just fucking it's fucking insane is what it is. It's fucking insane. But yeah, there's really not much more point to this than that I am giving people a little illustration of what it's like to be bipolar on this end of the spectrum, because typically I'm an incredibly calm person, you know, and I just, you know, this is not my typical demeanor, and so it's really funny. I don't know if this is typical of manic people. I don't know if it's, I mean, bipolar people. I don't know if it's typical really, and obviously it's probably exacerbated by the fact that I have extra serotonin in my system because I'm taking Prozac. But still, it doesn't make much sense to me why I should be dealing with this when I'm on Prozac. I guess it's better than the depression, because the depression makes me want to kill myself right now. I don't even know what I want to do. I mean, I want to listen to music. I was belting out everything. I had Teenage Wasteland on the radio on the way home from school, and awesome. You know, it's just I want to go out and do everything, and yet I can't even conceive of how to do anything. So that's kind of the ridiculous thing, you know. When I get in these states, I can't focus on any one thing at one time. I mean, I can't even focus on the fact that I'm doing this video, except for the fact that the computer is sitting right in front of me. So at least I know that much. But God, this is it's very strange. It's very strange. Anyway, so anybody who actually follows my videos, I'm sure you're gonna be probably kind of weirded out by this, but yeah, this is how fun it is to be me sometimes, I guess.
Okay, so there we go. I would absolutely love to have your impression of this video, but if you want to follow up and discuss with me, that would be great. My impression of the video here, hang on, it's a couple things. Oops. I hope I didn't shut that off. Hold on a second. It's still going. Okay. My impression of the video, things that stood out to me, obviously he had rapid speech, rapid thought process. He was rambling on, changing subjects, body shaking, excessive energy. He was even frustrated himself, moving around a lot. Said something about that he hadn't been sleeping, or he didn't think that he had slept, or something to that effect. Wanting to partake in that risky behavior. I think he said, I want to drive my car as fast as I can down the highway. I want to party and dance, and I just want to do something stupid. So I hope this kind of gave you a feel, you know, for what it looks like when somebody's having manic episode. The other thing I found interesting about the video is that he indicated that he was placed on Prozac. Again, and then he indicated because he was having some depressive symptoms. So I think this is actually a situation in which this person was misdiagnosed with depression, started on an antidepressant, which flipped him into an extreme manic situation. So seems like he does not have the right treatment plan. Okay, so let's move forward. Wanted to talk about suicide. Now, I know you guys know that, you know, there's a risk of suicide or suicidal ideation with almost all of our mental health disorders, but it seems that depression and bipolar disorder are a higher rate of that suicidal ideation, and that only makes sense because with their depressive symptoms they feel helpless and hopeless. Life isn't worth living. So suicide assessment and intervention is very, very important in these groups of patients. I just wanted to give you some information on different rates of suicide depending on the group. That might give you some insight into, the risks. Males are more likely than women to commit suicide. Adolescence, it happens to be the second leading cause of death in patients diagnosed with bipolar. Again, initially surfacing with puberty. I don't know if the suicidal rates are higher because they have not been diagnosed and it hasn't been caught, or if it's because of the severe depression episodes during bipolar. I can't say. Again, menopausal age women with bipolar are more at risk, and elderly over 65 related to secondary depression from chronic health conditions and the inability to control their medications at a therapeutic level. One thing that might give you a clue, again, remember we talked about after they start an antidepressant, getting that elated mood and energy just enough to perhaps go through with their suicidal ideation because they are still struggling with those depressive thoughts. Okay, so if all of a sudden, your patient becomes more cheerful, more energetic, be very, very concerned. On the slide, you can see that, there is on Blackboard something called the SAD person, which is an assessment tool for you. Basically, if you look down on your slide under assessment, that tool is trying to get at these questions right here. And so if you don't have a tool available to you, if you can remember the progression of questions that you need to ask the person to evaluate their suicidal risk, okay? So have they had any thoughts of suicide? If they answer yes, then your next question is going to be, do you have a plan? And then, do they have the means to go through with the plan, such as do they have a gun? Do they have, what am I trying to say? Do they have access to multiple medications to take an overdose? And if they have a plan and they have an idea of how they're going to do it, would it be lethal to them? And then have they made any preparations for their death? One thing that you look at is what they call direct threats or indirect threats. Direct threats is, I'm going to kill myself, okay? Indirect threats would be more subtle things, like all of a sudden they start giving away their stuff, or all of a sudden they want to get their will in order, or saying these vague statements like, bye, see ya, this may be the last time we talk, something like that. Those are considered indirect signals that they may give. Most, and then, I'm sorry, I didn't finish under assessment. Where and when? Did they plan where and when they were going to do this? Have they set a date? Okay. With each step along this assessment, the risk becomes higher and higher and higher the farther along that they've planned. Okay. Most people who are having suicidal ideation are pretty ambivalent and have really some conflicting feelings. They are not sure if they want to do it or they don't want to do it. And so these direct and indirect signals that they're putting out there are really actually, cries for help. Somebody help me. I just need help. Okay, so we have to pick up on those clues if we want to help this person. Interventions, obviously, your role is to keep the patient and other people safe. So if they're having suicidal ideation, one of the things is you're going to want to put some suicidal precautions in place. Again, removing any hazards in the environment that they could use to harm themselves. increasing that supervision. And like I said before, constant supervision is preferred. And then what they have found is actually if you sit down and engage in a no suicide contract with the person and get them to actually sign the contract, they have found that this has been very beneficial to deter the person from actually going through with any suicidal plans. Okay. Oh, I did want to mention that suppose you're in a setting in which you're not in a clinic or a hospital. Say you're nursing and you're doing home health, okay, and you think this person might be depressed, and so you start questioning them on if they've had any thoughts. At that point, if the person tells you that they're having suicidal ideation and you're in a home environment like that, you would be needing to call the police. And when you tell the person that, you know, their safety is really number one for you, and that you're going to have to notify somebody that they're having these thoughts, they're going to get agitated. They're going to kind of start to beg and plead, please don't call the police, please don't call anybody. And you just need to be very direct and tell them that their safety is first, and this is what you need to do to protect them, and not give into that pleading. People who are depressed or have bipolar, unfortunately, may have burned a lot of bridges within their social system, and that's because they partake in these behaviors. They can't keep a job. They've asked you for money over and over and over again, and so the support system starts to break down because people just get exhausted and they get tired of dealing with the problem. So you may have a lot of dysfunctional things going on within the family system related to their disorder. So what you need to do for these patients is build a social system within the community, because they lack that social system within their family units. And when you're building this system, it would include community support systems such as mental health clinics, hotlines, emergency evaluation services. If the person is in school, it could involve their student health services. If the person is religious, it could involve their church affiliations, just support groups related to their support groups for depression or support groups for bipolar, and any agencies that are going to be able to help the person financially, like medical assistance or food stamps or low-income housing or anything like that would be beneficial for the person. Okay, last topic, delirium and dementia. Just briefly, we're going to touch on these. I think in past classes you've had a lot of information on dementia, but I'm not sure if you have on delirium, so I'm just going to go over that briefly. Delirium occurs secondary to some kind of a medical condition, some kind of an acute situation, that if we treat the medical condition, the delirium will go away. So typically you're going to see delirium in the hospital setting where people are very, very sick, and they get very confused and agitated because they just don't know what's going on around them, okay? Dementia, on the other hand, is a vascular disease or plaques that are building up in the brain, causing some Alzheimer's. The dementia is a long-term, irreversible problem. It typically will disrupt their executive thinking, that is their ability to follow directions, their ability to perform math, like balancing their checkbook. It inhibits their ability to do routine things that were routine for them, like get up in the morning, eat your breakfast, take a shower, brush your teeth. I mean, they forget, and they don't have the capability to go through those routines anymore. So dementia happens over a long period of time. Symptoms progress over a long period of time, okay? Delirium and depression, the onset for that is rapid, like within hours or days, okay? So here's a nice little picture that puts the three disorders in comparison so that you can look at this and see what the differences are. A couple of differences that I noted that I just wanted to share with you. Again, dementia happens over a long period of time. The other two are a quick onset. As far as memory loss, the memory loss is true of dementia and delirium, but it is not true of depression, okay? These people with depression, they have decreased thought processing, but they really don't have memory loss, okay? Difficulty in finding words, that is something that is unique to dementia. Delirium and depression, they may have a slowing of speech, but they have not lost any abilities with their speech. Again, executive functioning impairment, writing letters, following directions, so on, that is also unique to dementia. Depression and delirium, they may be uncoordinated or disinterested, but they still have the ability to go through with these executive functions. So that ends our lecture for today. I hope that we have some fun in our class period playing our Jeopardy game, which hopefully will just solidify some of these concepts for you in a more fun way. So I'll see you in class.